Question 17. A 42-year-old woman with end-stage renal disease due to IgA nephropathy received a cadaveric donor kidney transplant 3 months ago. Her HLA mismatch was 6 out of 6, which means it was a complete mismatch. She had a low-level HLA type 1 donor-specific antibodies, but cross-match was negative though. She received basiliximab for the induction. She underwent an allograft kidney biopsy due to high creatinine. The biopsy is shown below. Which of the following is the most appropriate intervention? First of all, what you are seeing here, you are seeing two images. The first image is a light microscopic image where you can see severe tubular damage. You can see a lot of slough is there within the tubules, suggesting there is ongoing tubulitis and tubular necrosis, and there is significant infiltration of the neutrophils into the glomerulus, suggesting that there is glomerulitis. And you can see a lot of interstitial inflammation also that is going on. Along with that, you are seeing capillaritis as well. Within the glomerulus itself, there are a lot of cells that are present. So that indicates capillaritis. All these things tells you that there is some sort of rejection going on because this is a patient with kidney transplantation. And what is this? If you see this kind of images, it indicates a C4D staining. And C4D staining here is supposed to be positive because you are seeing a lot of brownish areas here. So whenever you have C4D staining positivity, it almost always tells you that it is an antibody-mediated rejection, or otherwise called as ABMR. This is something that we have discussed in the video lectures prior itself. So C4D staining positivity almost always indicates antibody-mediated rejection. So remember, in the presence of positive donor-specific antibodies, and if you have a C4D staining positivity, that almost fits into the criteria of diagnosis of ABMR as well, that is antibody-mediated rejection. The question asks, what is going to be the treatment of ABMR? So if you're going to have a pure acute cellular rejection, you can give pulse dose steroids, typically a IV methylprednisolone dose of 500 mg to 1 gram per day depending on the body weight. You are going to give for 3 days continuously, plus along with that you are going to start with anti-thymocyte globulin, thymoglobulin. ATG is something you have to start with. So this is very, very important therapy for acute cellular rejection. On the other hand, if you are having an acute antibody-mediated rejection, because it's an antibody-mediated rejection which is going to come from your B cells technically, so you need to go for corticosteroids, plus you need to go for plasma exchange, plus you need to go for IVIG to clear off those antibodies, plus at the same time, many times we tend to add rituximab, which is optional. If you want, you can add rituximab also. So the right answer for this question will be option C because you are suspecting an antibody-mediated rejection here. So I'm going to go for plasmapheresis, IVIG, and IV methylprednisolone plus or minus rituximab. Option D will be suitable if your question is suggestive of acute cellular rejection. And option B is also not correct. Because why option B is not correct? Because you're not suspecting a BK virus nephropathy here. That will present with a different picture. So you're not going to get C4D staining and all. Obtain donor-specific antibodies, yes, it's a part of evaluation of antibody-mediated rejection, but that alone is not going to be important here. Here they're asking about the most appropriate intervention. You can obtain donor-specific antibodies, but more important is to start the therapy here. So that is for antibody-mediated rejection, which is nothing but plasmapheresis, IVIG, pulse methylprednisolone plus or minus rituximab. So the right answer for this question is going to be option C.